Chronic suppurative otitis media, tubotympanic type. Chronic suppurative, we have discussed the classification of otitis media, acute and chronic. In acute type, we have discussed suppurative otitis media, that is presence of pus in the middle ear. Then non-suppurative otitis media, that is collection of sterile fluid inside the middle ear. In chronic type, we have two types of chronic suppurative otitis media, tubotympanic and aticoantral type. Tubotympanic is the mucosal disease, it is safe type, and aticoantral is the squamosal disease and it is unsafe type. So in unsafe type, we might have cholesteatoma, as it is squamosal disease and presence of squamous epithelium in the wrong place. So by the end of this lecture, we will discuss this scenario. So regarding applied anatomy, we have already discussed that middle ear cleft as eustachian tube, middle ear, and mastoid ear cells around the mastoid. So chronic inflammation will be inflammation of middle ear cleft for more than 3 months. Middle ear has seromucinous glands. Whenever there is inflammation of the middle ear, there will be increased production of serous and mucus inside the middle ear. These glands are maximum at the antero-inferior part of middle ear. So when inflammation is involving only the antero-inferior part, there will be increased secretion of the middle ear seromucinous glands. As bones are present in the postero-superior part, these ossicles are mostly in the attic part of the middle ear. So involvement of bone in this region is rare. So it is only the involvement of the mucosa. So tubotympanic disease or any disease that is related to eustachian tube dysfunction, related to nose and paranasal sinuses, is related to abnormalities in the nose and paranasal sinuses. So it is common in children because children has short, wider, horizontal and poorly function eustachian tube. You can see this small injury. It is simple injury, safe type of injury, but if you are not treating this, it can be converted into dangerous injuries, can lead to septicemia. So definition of chronic inflammation. What is chronic inflammation? Chronic inflammation is the inflammation that lasts for more than 3 months. In this inflammation, healing and destruction are taking side by side. So when we define the tubotympanic disease, it is inflammation of middle ear cleft for more than 3 months and it involves the mucosa only. So what is middle ear cleft? Middle ear cleft include middle ear, tympanum, eustachian tube, mastoid antrum and all their cells that is surrounding the mastoid. So what is the pathophysiology? It is the localized inflammation of middle ear cleft usually involving the antero-inferior part of middle ear. Limited to mucosa only, healing and destruction are taking side by side. Increased production of seromucinous secretion because of stimulation of seromucinous glands. Characterized by central perforation. You can see in this picture central perforation. What is central perforation? Central perforation is the perforation that is surrounded by pars tensa. So there are different types of central perforation. It can involve the anterior part of pars tensa. We call it anterior perforation, involving the posterior part, posterior perforation. Inferior part, inferior perforation, involving more than two quadrant of the pars tensa, subtotal perforation involving the whole membrane, that is total perforation. We divide the pars tensa into four quadrants. Vertical lines passing through the handle of malleus and horizontal line through umbo, that is the lowest part of the handle of malleus. So antero-superior quadrant, antero-inferior quadrant, postero-inferior quadrant and postero-superior quadrant. Small perforation when it is present in one quadrant, medium perforation when it involves two quadrants, and subtotal and large perforation more than two quadrant perforation. So etiology is related to nose, paranasal sinus and diseases of nasopharynx. Then infection can transfer from external ear to the middle ear through previous perforation. Repeated attack of acute otitis media can lead to chronic form. So ascending infection from eustachian tube seen in allergic rhinosinusitis, infective rhinosinusitis, large adenoids, DNS and cleft palate. Then ascending infection can be through nasopharynx, through eustachian tube in cases of chronic tonsillitis, pharyngitis, low respiratory tract infection, chronic laryngitis, bronchitis, bronchiectasis, pneumonia. Reflux esophagitis. When there is reflux of the acid, it can lead to inflammation of the eustachian tube. Eustachian tube gets blocked and sometimes infected, so infection can go through eustachian tube into the middle ear. Smoking leading to inflammation and obstruction of the eustachian tube. So now the pathogens. Pathogens are usually gram-negative, sometimes Staph aureus, that is gram-positive cocci can also be seen in this chronic inflammation. Usually it is Pseudomonas aeruginosa, Proteus E. coli, and if you are giving antibiotic and there is no improvement, chronic Mycobacterium tuberculosis infection can be considered. Anaerobic bacteria are also important. So mixture of aerobic and anaerobic bacteria in aerobic gram-negative bacteria are common, can cause chronic inflammation of middle ear cleft. So what will be the clinical features? As there is perforation, so patient will complain of ear discharge. Anteroinferior seromucinous glands are moved, so there is production of seromucinous secretions that is profuse, as it is limited to mucosa only, so this secretion will be odorless. Because of perforation and accumulation of pus inside the middle ear, it will cause, patient will complain of hearing loss, and this type of hearing loss will be conductive hearing loss. Then there will be symptoms of associated disease of nose and paranasal sinuses. There may be nasal obstruction, there may be nasal discharge, there may be recurrent acute tonsillitis, there may be history of mouth breathing. When you will examine the middle ear or you will examine the tympanic membrane through otoscope, you will see central perforation. Central perforation that is surrounded by pars tensa. Through perforation, you will see the mucosa of middle ear that will be inflamed and edematous. You can see in this picture, this is normal tympanic membrane, pars tensa, lower 2/3, pars flaccida, upper 1/3. In this picture, you can see anteroinferior part is the cone of light. This is left tympanic membrane and this is right tympanic membrane. Then clinical examination, you will perform complete ENT examination to rule out any disease of nose and paranasal sinuses and tonsils. Otoscopic examination, you will see central perforation and you will confirm your diagnosis by examination under microscope or examination with the help Then you will confirm your diagnosis with the help of examination under microscope and examination with the help of telescopes. Then you will perform tuning fork test to assess the type of hearing and to assess the severity of the hearing. So Rainey's will be negative, showing conductive hearing loss, and Weber will be lateralized towards the same ear. So you will put the tuning fork first in front of the ear, then on the mastoid. Patient will hear better when you will put the tuning fork over the mastoid. So it is Rainey's negative. So patient is hearing better through bone. So Rainey's is negative and Weber will be lateralized towards the same ear. You will confirm your tuning fork test with the help of audiometry showing ear bone gap and conductive hearing loss. Then, because patient is in chronic stage and there is no improvement with the antibiotic, you will send pus for culture sensitivity. If patient is not improving with ear drops and antibiotics, then you will rule out mastoiditis by advising X-ray and CT scan. X-ray of sinuses and adenoids should be taken to rule out any disease in the nose and nasopharynx. So these are the tuning fork tests we have discussed. Rainey's will be negative, bone conduction will be better than ear conduction. Weber test, the patient will hear better. Weber will be lateralized towards the affected ear. In cases of sensorineural deafness, Rainey's will be positive and Weber will be lateralized towards the opposite ear. But in this case, we will see conductive hearing loss. So this is Rainey's test. Patient, first you will put vibrating tuning fork in front of the ear, then over the mastoid. Patient will hear better when you are putting the tuning fork over the mastoid. So it is left ear. When you are performing Weber test, Weber will be lateralized towards the left ear. So this is audiogram. Normal hearing, there is ear bone gap. This is showing air conduction and this is bone conduction. Air conduction will be lower than the bone conduction, so there is ear bone gap. So this is conductive hearing loss, and you will see ear bone gap in this tubotympanic disease. As a comparison, you can see this is sensorineural hearing loss in which both graph will come down. But in this case, chronic suppurative otitis media, you will see this type of audiogram showing ear bone gap. So X-ray of the adenoids, you can see adenoids in the nasopharynx, sinusitis in the maxillary sinus is hazy. So you can see, you will rule out any sinonasal disease with the help of X-rays. And if patient is not improving and you are advising X-ray mastoid, you will see sclerosed mastoid, non-pneumatized mastoid, and septa in between the cells are destructive. So this is coelion of the mastoid ear cells showing mastoiditis. So in cases of mastoiditis, you will have to treat mastoiditis. So complications, mastoiditis, edematous mucosal polyp, tympanosclerosis. Tympanosclerosis is the deposition of the calcium salt over the tympanic membrane, in the tympanic membrane. Then fibrosis, adherence. The tympanic membrane get adherent to the promontory. There will be fibrosis in between the ossicles. Ossicular chain necrosis, because inflammation will hamper the blood supply of long process of incus, it get necrosed. So all these things will lead to hearing loss, that is of conductive type. So what treatment will you give? Treatment is very simple. First of all, you will give medical treatment. You will clean the pus with the help of suction, and then you will prescribe ear drops. Ear drops will be in the form of antibiotics containing steroids. Systemic antibiotics can also be given, and all these antibiotics should be effective against Pseudomonas and gram-negative bacteria. Then you will advise the patient to protect ear from water, and you will also treat the cause of disease, that is adenoids, allergy, and DNS and sinusitis. You will treat these causes. So if patient is not improving, then you will advise X-ray and CT scan mastoid. If there is mastoiditis, or if there is formation of polyp, formation of granulation tissue, then you will think of surgical treatment. What are the surgical treatment? You will remove the polyp, you will do exploration of the mastoid, and you will do canal wall up procedure. Only cortical mastoidectomy is sufficient in cases of tubotympanic, safe type of disease. You will make a air reservoir, and you will remove the infection from the mastoid. So if there are granulations, you will remove the granulation. That can be removed with the help of cauterization, or you can pick this granulation with the help of forceps. After removing the infection, when the ear becomes dry, you will wait for 6 months, or at the time of operation, you can also perform some reconstructive surgery, that is laryngoplasty and tympanoplasty. If only the tympanic membrane is damaged and ossicles are intact, then you will put graft over the tympanic membrane, that is called laryngoplasty. If ossicles are damaged, you will make some ossicles with the help of some bone, that is called ossicloplasty. So then after treating this, or before treating it, you will also address the disease of nose and pharyngeal sinuses. All this about the tubotympanic disease. Now we will discuss the scenario. Ahmad, 24 years of age, came in OPD with a history of right ear discharge for the last 2 days. Discharge is odorless and profuse. He has history of recurrent nasal obstruction since childhood. On otoscopic examination, central perforation is seen. So, points in favor of tubotympanic disease: odorless, profuse discharge, history is prolonged, and child is the age of the patient is child. So, and otoscopic examination, there is central perforation. So, diagnosis is in favor of tubotympanic chronic suppurative otitis media. Pathogens and pathogens we have discussed are mixed pathogens. Gram positive is Staph aureus, gram negative are more common, along with anaerobes. So management plan is, you will diagnose your case with the help of history, clinical examination. You will do otoscopic examination, you will perform tuning fork test, you will perform examination under microscope, endoscopic examination with the help of telescope. Then after if patient is not improving, you will send pus for culture sensitivity, and if you are suspecting associated mastoiditis, then you will advise CT scan, and along you will give medical treatment in the form of antibiotic drops or systemic antibiotic. If patient is not improving, then you will think of surgical treatment. Surgical treatment is cortical mastoidectomy, that is canal wall up operation. You will clean the mastoid ear cells, and you will do reconstructive surgery of tympanic membrane and ossicles. So then there is another question. 20 years, presented with unilateral profuse odorless discharge for the last 8 years, associated hearing loss, right-sided nasal obstruction. Otoscope will reveal the big perforation, DNS is present. So again, the diagnosis is tubotympanic chronic suppurative otitis media. Management is the same, and complications of the disease, complication of chronic suppurative otitis media in safe type are deafness, tympanosclerosis, adherence, mastoiditis, and deafness is the hearing loss, that is of conductive type. So management is the same as we have discussed in previous scenario. oral toilet, antibiotics, treatment of the cause. Then, if patient is not improving, think of surgical exploration of mastoid, that is in the form of cortical mastoidectomy, then reconstructive surgery. Complications are usually tympanosclerosis, adhesive otitis media. Another scenario, a 30-year-old patient complaining of deafness, non-smelling, profuse ear discharge for the left ear since childhood. Examination, tympanic membrane is intact and choppy deposition and retraction pockets. There is no So that's all about the tubotympanic disease.